No, that's great. So thanks so much, and it's great to hear. So as I had put this together, I was really thinking about, or I was thinking that the charge was a little something different on community engagement, but that's okay because I've just restructured some things and now I'm ready to go. So um, what I'm going to do is, through the lens of the work I do as a kid, as a nephrologist, um, sort of take this approach that we've been discussing in nephrology, right? And so in the kidney area, medical students have been leading the effort to remove race from kidney function estimates. And the medical students say race is a social, not a biologic construct. And what the nephrology community says, yes, we agree absolutely. And then we continue to use race as a biologic construct, right? And so this description, this one student was very upset when Black race was used as an adjustment and a proxy, and instructor said, well, and all of us said, well, from the original research said, well, we think it's probably related to increased muscle mass. And to think that every Black person has more muscle mass than every non-Black person is sort of crazy, right? And Arnold Schwarzenegger would be pissed, like, if he didn't get some modifier added to his GFR, right? Because it's due to muscle mass, right? So these coefficients first came out. There were two studies. One was the modification of diet and renal disease, and the other was the African-American study of kidney disease and hypertension. So I was involved in the second one. And both of these studies had measured eGFRs using iothalamate clearance and then estimates from formulas. And there was differences in the estimate and the measured between Black men, white men, Black women, white women. And so this modifier was developed. And that's what we use now. And so as we go forward, the big dilemma has been, particularly in the nephrology community, some people saying we should not change science just because people want social justice. And the other side saying we should not do less than our best science because we don't understand how to use race as a variable in medicine, right? And so that would be my position. And then people say, again, yes, race is a social construct, but I'm going to put in this formula just as if it works like age or serum creatinine or hemoglobin A1C. So in science, I think we first need to understand what race is and how it should and should not be used in medicine. And then we can determine what to do with it as far as whether or not it should be used in formulas or algorithms. So right now they're in formulas and algorithms, and it's sort of like, well, you have to prove to us why it shouldn't be there. And I think that's the wrong approach. So most of us know that it's a socio-political construct. It's been used to, at a societal level, to control and populations, to marginalize populations. And as used, it's developed from white supremacy ideology, which is the ideology of race superiority. And it was used originally to maintain and to justify and maintain American Indian genocide and oppression, chattel slavery, and it's continued on. And we in the medical profession and the health sciences have been complicit over the years in proving either actively or passively that race is biologic, right? And the whole thing was the whole scenario is to sort of say, well, no, I just didn't, this is really biologic why this group is less than. And part of the challenge in medicine has been an impression that race is directly related to something biologic, right? And usually it's thought to be directly, or in the articles, they're talked about being directly related to ancestry or population genetics. So it was a recent article within the last year on a racial reckoning in the New England Journal of Medicine. And in there, it talks about race being directly related to ancestry. And I hope when we finish, no one will believe that. Okay. So as a research variable, it's a very poor indicator of biology. And what it is race and ethnicity as sex are strong indicators of exposure to racism, sexism, and they will vary depending on the society you're in and how the groups are stratified. So what race actually equals is how society sees you and thinks of you. That's the science to race, right? Some people will look at one person and say they're one racial group or ethnic group. Someone else will say it's something different. So there is no consistent definition or way to measure race. So as a variable, that's not really like a very good variable to use in science if no one can agree on what the variable actually is. Right? So that's the first point. Racism, a lot of people get upset about racism, but racism is a system. It's not, and a system of structuring opportunity, assigning value, and it can advantage or disadvantage communities. And this is from Kamara Jones, and it saps the strength of society through waste of human resources. And there are different levels of racism. I try to focus mainly on structural racism that is sort of embedded in the systems. And that's what stratifies resources and opportunities to communities. So race is how society sees you. Racism is what society does to you based on how it sees you. Okay? From a research perspective, and this is from Tom Leviste, who was at Hopkins, is now the Dean of Public Health at Tulane. He developed this conceptual model of looking at race from a research perspective, that race is a sort of unmeasurable, unobserved, this sort of latent variable. It's, we look at people, we look at their skin color, their facial features usually, and we assign them a race or ethnicity. And somehow that then relates back to this unobserved, unmeasurable element of a person that is their quote unquote race or ethnicity. But once they have that assignment, they are now functioning and operating through society. They may have, as a group, they may have certain cultural behaviors, beliefs, and practices they engage in. Some of those may be longstanding over decades or centuries. Some may be adaptive to how they function or can best function in a society. And all of those lead to a variety of health and wellness behaviors and risks that lead to the health outcomes that we see that differ by groups. So we saw this most clearly with COVID-19. And we're fortunate here, we're working together on the Big Seal Initiative, UCI, UCLA, and many of the other CTIs in California to address and try to have a positive impact on COVID-19 in low income and marginalized communities. But it made disparities clear to people who typically are not actively working in those areas, right? And so we saw increased risk of exposure to the virus, high chronic disease burden, lack of access to care, and all the downstream effects that then put someone in a position to either get the virus or get complications from the virus. Right? And we saw that predominantly racial ethnic minorities were 2 to 4 times more likely to have most of these complications, but it's not anything intrinsic about them, about their personal identity. It was that they belong to a group that is stratified in society and more likely to be exposed to the lesser amount of investment at a community level based on residential segregation, underfunded schools, higher rates of poverty, chronic discrimination, and others. And so Dr. Don Berwick, former director of CMS, said every system is perfectly designed to achieve the results it gets. And so we need to change the systems if we're going to change the results. So how do we use race and ethnicity in medicine? So for COVID, while we may say a racial ethnic group has 3 times the rate of COVID infection, let's say that, we would not say, or should not say, every member of that group is 3 times more likely to get COVID or to be hospitalized or die. Because every member is not exposed equally to those to those risk factors, and there are members in other, and so across groups, there, you know, within each group, there's different levels of exposure, and so it's really not an individual risk; it's a group risk. And what the group risk tells us is that person may be more likely. But how we should use race and ethnicity in medicine is it's a population variable, really. So we should use it at a population level for ascertaining differences, for doing community messaging, education, initiating, implementing interventions and or policy changes, and then following up to see if we have improvements. So as I sort of wind up, I want to go through what I look at as this description to try to clarify for a lot of people why they saw the COVID-19 disparities, right? Because everybody's like, oh, I don't understand why that happened, et cetera, et cetera. And while we have a narrative that we have a meritocracy in America and that everybody has the opportunity to climb this ladder and reach their goal, that in fact is not true. And we have a variety of pathways. And I have 3 ladders here. There's more than 3, but just as an example. And some people have a much shorter ladder to climb, supported through laws, policies, practices. They still may have to work hard to get to the top, but they have that support. Others have fewer boxes. They still may have to work hard, but they have fewer boxes. But there's a ladder. It not only does not have boxes, the ladder is in a hole because of laws and policies and practices that specifically are directed to negatively impact a particular group of individuals. And there's a lots of different laws, and some are better than they were, et cetera, et cetera. People talk about, and we saw a lot of this, well, after the civil rights, didn't all that go away? So after the Civil Rights Bill, not the 1866 Civil Rights Bill, but the 1964 Civil Rights Bill. So it was already another Civil Rights Bill 100 years ago, 150 years ago, but the 50-year-ago bill. After that bill, what we saw was fewer laws to create a deeper hole. But that bill had nothing in it to fill that hole, okay? But more than being in the hole, the ladder is broken that people have to climb up. And so there's implicit bias, underfunded schools, microaggressions. And we talk about the pipeline programs, and I do a lot of work with pipeline programs, and I think they're important. But a pipeline program says, we need more people in climbing that ladder. But they're getting in a ladder that's in a hole and it's broken. And so putting more people on that ladder will lead to more people reaching the top. But it is a very poor and tragic approach to achieving equity. And so for a lot of the pipeline work I do for increasing diversity in the biomedical workforce, I have to be cognizant of the dilemma around, you know, I want to do everything possible to give people these extra, this extra assistance, but at the same time, as long as these programs are needed, it means fundamentally we're still structurally flawed, okay? And so what we need are structural changes that fill in the hole, give a couple boxes, and fix the ladder. And there will never be a time in our society where everybody has the same number of boxes. That's okay. Well, life doesn't have to be fair. Life's not going to be equal, but it shouldn't be so unequal, right? And so that's the issue. The issue is how unequal is appropriate. And so I think that when we talk about equity, we're talking about filling in the hole, and justice is what's needed to make that hole be filled in. I also want to bring up to people's attention, what you frequently hear is any attempt to fill in the hole or to fix a ladder, if those resources are not also given to other groups, that's called reverse discrimination. Right? So you have to be cognizant of the difference between equality and equity. You don't want to treat everybody equally when they're starting out unequal. Equity is to bring everybody to a level playing field, and then equality is a reasonable approach, but otherwise it is not. So let's shift gears from the social part and let's look at the biologic part. So in kidney disease, we have a risk allele that's associated with increased risk of kidney disease. And this allele is linked to a gene variant that's thought to protect people from the adverse effects of sleeping sickness. And so in a few areas where there's high rates of trypanosomiasis in Africa, this allele is more prevalent. And what I show here is the prevalence of this allele in these 4 different ethnic groups in Nigeria, ranging, and the high risk, and you need 2 high risk alleles to have to be more likely to go on to kidney failure. And it ranges from 2.1% to 49% in these different communities, okay? In the United States, because of the slave trade, many people came to the United States from certain areas in Western Africa, and in African Americans in the United States, and people of African descent in North and South America, as well as the Caribbean, there's a fairly high prevalence of this APOL1 risk allele. And it's estimated that as many as 10 to 13% of people who self-identify as African American have this allele. What it becomes called is that this is a gene that's linked to being black race, and it's not. Like sickle cell, the genes are not related to being black. The genes are related to being in an area where there's a high prevalence of trypanosomiasis. Sickle cell is related to being in an area where there's high rates of malaria. And if you're in Africa, that's it. But if you're in India or the Mediterranean and you develop, and over time, sickle cell becomes prevalent, no one says that's a black gene. That's a gene that just happens to be a gene you have. So these formulas operate under the impression that someone who self-identifies as black is somehow you automatically know their risk for certain gene variants. And even if you knew someone was from Nigeria, you wouldn't know, their risk of these gene variants range from 2 to 50%. But if they're from other places in Africa, their risk is close to 0. So self-identified race has really no relation to even population or continental ancestry, and knowing continental population ancestry has really no direct relation to a particular gene variant. So we want to know a gene variant, and if it has an association with the disease, then we want to measure the gene variant and not someone's race. So medical students, I think they were right to request race be removed from the formula. Not because it's a social justice issue, but it's in the interest of best science. For the people in the group who are part of the bioepi group, you're probably more familiar and better versed than I am with understanding what's termed the ecologic fallacy of these analyses, where we're taking variables that are nominal and trying to then infer group level information relative to the individual. So I think we've used a complex social construct in a flawed methodologic manner in medicine. Public health doesn't do that, but in medicine we do it, and we continue to do it, and we still have ethnicity and race in all sorts of formulas. And so based on that formula, actress Kerry Washington gets 16% added to her EGFR because of quote unquote her muscle mass. And Arnold Schwarzenegger gets 0 added to his EGFR because of quote unquote muscle mass. And yet we think this is, the most rigorous science that exists. And so we have this flawed approach to using race and ethnicity in science, and hopefully, particularly driven by the passion of the medical students, we will remove this flawed approach from what we do. So race belongs in medicine because it is an essential part of social history, not because it approximates genotype, and we should use it at a public health level, but not in formulas or algorithms. And we should do it not because of social justice, but we should do it because we want to do the best science. So I'll stop there, and happy to entertain questions, comments, et cetera, et cetera.
I have a question.
Yes.
So
could folks raise your hands, and that way, and I'll try to moderate, and Joni and I'll try to moderate, and I'm sure there'll be a lot of questions. First of all, Keith, thank you so much for that. We really appreciate it. Very stimulating. I think you're going to have a lot of questions.
Cool.
it was fantastic. Thank you so much. And I was like with you the whole time. However, what we see in our maternal outcomes, infant and maternal outcomes, seems very race related, and I can't seem to justify that in my head.
So yes, so a lot of things are race related, but it's because of what happens. It's by and large, it's because of what happens to a group because of how they're treated in society and the impact of structures on society. So in maternal outcomes, it may be, we think more about the effects of stress and its impact on allostatic load, on neurohormonal activation, on epigenetic changes in genes that can have an effect on maternal fetal outcomes. And so those seem to be fairly consistent. What people have said frequently is, well, there must be some gene related to being Black. That's the reason why this is happening, right? And so there's no evidence of that, but there is plenty of evidence of all the other things. And so I think until we can control for all the other things, then at that point we can start thinking about, is there I would say a gene polymorphism that may be at risk. But the gene polymorphism distribution is sort of global. It may be more common in some groups than other groups, but it's not really related to, but the gene polymorphism is related to, it just happens, right? Wherever it happened in the globe, and so some groups have it and other groups don't have it, or it was promoted and enforced by environmental changes, et cetera. So there could be populations from certain areas where it may be more common, but it is not. The problem is the designation of race, which is a socially designated and constructed term, is not directly related to ancestry or genetics per se. But I think as a group, one could say this group that has undergone and been subjected to A, B, and C may be more likely to have these epigenetic changes, these neurohormonal changes, and that may activate, when we think about all the gene environment interactions, something in there. Well, we know at the end of the day, we know something in there leads to worse outcomes.
Yeah, I think I had the chance and opportunity, wonderful, to work with a group of medical students and nurses from Cameroon. And what we saw is that if you correct for poverty, nutrition, education level of the mother, then their birth outcomes were equal, if not better.
Perfect.
So it's being American that causes the problems. So I'll shut up now.
No, thank you.
Other questions, comments? Keith, I'm struck
you.
by sorry.
Yeah, I
who is
did
that?
raise
Is that
my hand.
Deli? Go ahead. And you know what?
Thank you.
If everybody could just introduce yourself so Keith knows who's attending. By the way, you heard from Pam Pimentel. You may have met Pam.
We
She's
met them doing the, we were working on another project together.
right.
with,
So Pam's one of our fantastic community folks and led a wonderful
Right.
organization in Orange County for many, many years to help antepartum care, prepartum care for women, and has done great work with us and across the country. Deli?
Thank you, Dan. It's hard to follow Pam because she's been all over the world and done a lot of great things. But thank you, Keith. Very, very insightful conversation that you're stimulating with these presentations. As a Nigerian, I now have given up my interest in finding out if I have any of the APOL1 alleles. But it reminded me of the conversation I had with my physician on an anti-lipidemic medication and the formula that's used there. And I talked to her about my work on another allele, ALAD, for vulnerability to lead poisoning. And we don't have it in the African population in general. Whereas if you look at Brazil and the US, you see as the population mixes that you have different ratios of the allele in the population. So it reminded me also of the debate between personalized or precision medicine, where such information may in fact be useful, and the resistance and among those who resist introducing that idea to public health, because we in public health think about generalizations. We want the best for the most, and identifying vulnerable people is part of the framework. But it's too soon, in my view, to go into that level unless we're in Iceland, where you know the genome of every individual in the population. We're not yet there. So I just want maybe your thoughts on where
Sure.
this might be relevant to look at this level of genotypes and vulnerability indicators, and where it really cannot be used because we just don't know enough. Thank you.
Yeah, no, great question. So I see, right, so public health gives us data at population levels, and if we see differences, that's helpful, right? Because this is something different's going on, right? And usually at a population level, it's primarily driven by differences in how populations are treated, access to resources, et cetera, et cetera. There are instances where there could be differences in the prevalence of certain alleles between groups, whatever those groups are. And that's an easy way to capture that particular allele may be associated with a particular disease condition. Once we can identify a linkage between that allele and that disease condition, then for personalized medicine, we can, if we're interested in an individual having an additional risk for that medical condition, we can measure that allele. What we should not do is say, you're a man, you're a woman, you're Black, you're Asian, you're white, therefore, I'm assuming you have this allele. Yeah, right? If we want to know if precision medicine is precise, right? So you have to measure the allele. You can't look at somebody and say, oh yeah, you have, this lipid allele, or you have this whatever allele. So we don't want to, and we can't at a group level, the variations are so different, it's really not that helpful at a group level to think about the, how we'll use the allele. So for me, I think the alleles are helpful for that we want to measure those precise, at an individual level. I think when we take care of a patient, right, I think to say, if the allele is 1.08, its prevalence is 1.08 higher in a group of people that we label as Asian, let's say, in America. Like, really, what does that mean? Asian in America.
Right.
So is that allele the same in people from Japan as it is from Thailand, from India, from Indonesia? But that's how we do it, right? So it is, so race has is like a poor guess of continental ancestry, which is a poor guess of what the prevalence of some particular allele distribution is across this large geographic area. That makes it really impossible to make those two connected. So I think if one has a concern, we measure the allele, and we measure the allele because they have the disease, they have a disease condition, or there's some other reason why we think they may be at risk for a disease, and not just because of their race, ethnicity, or their gender.
Perfect. In the lead situation, it's about whether or not one works with lead, right? So, and I think the tension in public health is our eagerness to not support segregation of populations. We like, to have a diversity, communities are diverse, but we also want to use these measures that overgeneralize. And so, well, thank you. I really appreciate your insight into this.
Joni has her hand up.
Yeah, I just wanted to kind of piggyback a little bit on what Dele was saying. So you all know that my background, my PhD is in epidemiology, but obviously I work doing a lot of kind of methodology and statistics on campus. And I end up having these conversations a decent amount with researchers who want to include race and ethnicity in their models. And I remember I had a conversation with one of my statisticians who had a group of researchers, I won't say what department, but they basically wanted to use race as a treatment, where they were going to be, and there was a paper out of JAMA that used race, and they predicted the probability of being Black or white, and they used that as a way to like match individuals and in order to look at some outcome. And I remember thinking this was just the oddest way of examining race, because I was like, you're just conflating all the things we were talking about, right? Just conflating so much about the biology and the social aspects of what race is. And I ended up having to have a kind of a long protracted conversation with my staff and with this research group of why that was problematic. And just because something had been published doesn't necessarily mean that it was an appropriate way of using race in any kind of paper, any kind of research. And so I feel like I'm always kind of straddling that line of understanding, the kind of the historical context of how people use race and the idea, and obviously I understand it's a social construct, but then also trying to explain that to researchers as well about why it's problematic.
Right. I mean, World War II was fought over like racial superiority, right, between Germany and primarily what Hitler thought more than anybody else, Russia was, right, and the people in Russia, right, and so race is just, at some point in time, people say, I think this group of people are better than that group of people, however you want to do it, right, and then you make up, and then you reframe it. Right, and that's the amount of science we have behind it, but but because particularly in America, because we have structured resources between groups so significantly, we can see differences in outcomes, and they reify this belief that there must be these differences between groups because we see it, and we would never give resources differently, so it must be the individual's problem.
Dara, you had a question. Did you want to go ahead and ask it? You put it in the chat box, but why don't you bring it up?
Well, as you were talking, I think you answered it a little bit, Keith, but I was struggling with, I was playing in my mind these ideas of like ancestry, genetic, and then ultimately ethnicity, and whether or not you felt ethnicity was also the treatment of how we treat ethnicity. Would you put that in sort of the same bucket of race? I guess maybe my question still stands, because then you went and said, I think you did, but I do struggle a little bit. You cleared it up quite a bit in the conversation, but in my own work, as somebody who studies the impact of race and ethnicity on a number of health and health outcomes, part of the value of being able to bucket people, because ultimately scientists are bucketers, right? We're looking to make statements in buckets, is helping to help draw out some of the health disparities that we've seen or were unnoticed for so many years and ignored. But anyway, do you think of ethnicity as being sort of a similar, fraught with some of the same landmines as race, or is that closer towards trying to identify what is it about how people have moved through the planet that create perhaps similar genetic profiles? Like I'm an Ashkenazi Jew. They ask me about my BRCA status when I go to get my mammogram. Is that the right, is that the right question?
Right. So great. So yes, it's ethnicity is another similar construct. I think for a variety of reasons, people in a certain group, one could say, we have data that, that your group membership, this group has a higher rate of A, B, or C. And we don't know what that is, so, and if we see there are higher rates of breast cancer in a group, then that's helpful. And so I think what we don't want to say is each person in the group has a 1.x risk for this, right? So we can't infer what the individual risk is. And at a genetic level, your risk is you either have that gene or you don't have that gene. I think it is, what I would hate to see a formula that says, so we can say there's higher blood pressure in the African-American community, but we shouldn't create a modifier and add or subtract a certain amount of blood pressure to every Black person's blood pressure, right? So we measure their blood pressure, and their blood pressure is what it is. Now, what I would do is, I think knowing that we have this information of group membership, I might say your blood pressure is normal. That looks good, but you're a member of a group for whatever that has a higher likelihood of having high blood pressure. So what I like to do is measure your blood pressure 3 times a year rather than 2 times a year, right? Or I would say, you might say, you're a member of this group, therefore we want to check you for these markers for breast cancer, or these markers for colon cancer, maybe earlier, because we see it happening early. We don't really know why, but we see it, it's there. So we want it. So I think for screening, for education, for messaging, that's very important and very useful. And then when I think of it like in seeing a patient, then I think not that it should be in a formula that gives them a number, but I can say, you're a member of a group. In my mind, you're a member of a group. So what we know about this is, if it's COVID, I'm more interested in knowing in your household, the number of people that are there, where you work, your transportation, whatever risk factors, I want to go into those in more detail. If it's something that I think is biologic, if there's a family history, your particular family has a history of breast cancer or colon cancer, then I'm going to, now I'm going to start ordering the individual tests. But I wouldn't go to every minority researcher in the country and say, oh my God, right, who's on these Zoom calls and working remotely, and say, oh my God, you're 4 times greater risk for dying for COVID right away. What's going on, right? Because we know they're not. So it is informative. we just have to be mindful how we use it, I think.
So Keith, if I can follow up, first of all, you know, the nephrologists as a group always forget about the pulmonologists. I just want to make that point to you nephrologists. And so I put in an article here about how race has played a bad role in spirometry, where you probably are aware of this history as well.
You're the leader. Pulmonary is the leader in this. I think pulmonary was the first, the first group to put it in.
No, but I just wanted to make a comment for someone who's maybe a little older than a lot of people here, and has paid attention to this throughout my whole life, and remember when the civil rights, not the one from 150 years ago, but the one from 50 years ago, and how much their work there is to do is, you know, some of us, you know, we really found aspirational this idea that we would deracialize the society, that we wouldn't think about people this way. And then in the last couple of years, it's almost as if we're re-racializing. But your talk is so hopeful to me, Keith, because when you talk about precision medicine, and when you talk about let's really look at the data and let's judge people correctly and not use these shortcuts of, oh, this person is an Asian or this person is an Ashkenazi Jew, and I have nothing against Dara because of her Ashkenazi Jewish background. I find that enormously constructive and hopeful. And my question for you, though, is, in the last couple of minutes, if you could advise us. So you really pointed out, we've got a lot of work to do. We have a lot of work to do to get to that point where we can have a relatively unbiased society, where we treat people, every person, with dignity and respect and scientific, you know, rigor.
Right.
What can we do here at the UCI ICTS to make that happen? What tools do we have within our local, regional focus, our supportive research, our supportive training, to help bring about these goals that you so eloquently identified?
Yeah, a great question, Dan. I wish I really knew the answer, but I think one of the most important things is, we, particularly from a scientific perspective, we need to be cognizant of where we see racialized, I wouldn't say where we see elements of inappropriate use of group stratification that is reinforcing racial narratives of inferiority, superiority, right? Because that's the real thing. See, differences exist, that's fine. And there should never, we should celebrate because differences allow us, they open our mind to something we would not have seen before. So differences should be embraced. It is the taking differences and labeling groups as inferior and superior where the problem becomes. And so when we think about the work we do to make sure that we are always messaging differences in a way that is not reinforcing these racialized stereotypes or racist stereotypes, really, and to use it and to think about it in a, how it can be used in a more constructive way. And so in the formulas, it is, when I think about the EGFR, when they created the formula, I don't think anybody sat down and said, how can I get more Black people on dialysis? Let's do this formula, right? So no one was trying. So I don't think of it as being racist because the intent wasn't to denigrate or to disadvantage a group. But it's an unconscious continuation of this sort of this concept that there is a biologic essentialism in racial differences, right? So that's one thing we need to get away from. So anything we do in medicine that reinforces this biologic essentialism, that anything we can do to eliminate that is, I think, helpful, or to bring that conversation up and move away from that is helpful. And so those are the things that I think are more or steps and strategies we can take. And that's the first thing that comes to my mind. I'll have to think about that and figure out what we need to do.
Well, but I will say, Keith, that in the case of spirometry, it actually was used to prevent African-American people from getting benefits from exposure to various workplace toxins, where they said, well, we can't use the values because Black people generally have lower lung function. So we're not going to give them, they're not going to be included in these things. So that really was an example where it was used in a very racist way, in a very negative way, unfortunately. Yeah. I see we've got Steve.
I just want to say something really quickly, Dan.
Yes,
Keith is he understates what he's done to work on the pipeline, the talent pipeline in biomedical work. He's there with Elizabeth O'Feely and others pioneering the National Research Mentoring Network, using his position to open up and create spaces at the table for really talented minority scholars all over the country. He's also educated community partners all throughout Los Angeles to, again, partner with UCLA. And I just want to highlight, I think we really see his academic gifts and how he's provided nuance to the thoughtfulness around race and ethnicity, but he's also I really think been a pioneer for making NIH and others think about how to create inclusive workspaces. So I know he's also mentored, I think, Arlene Brown, right, who we're seeing take leadership in the CTSA and other really prolific scholars. So just to say, I think leadership and saying what you say, not only saying this matters, but living it out as a leader in an institution.
Thank you, Maritza.
Thank you, Maritza. I wonder.
And he didn't pay me anything to say that. I just want to make sure people on the call get that Keith is a leader, pioneer.
Next time I will. Next time
you come, we need to see your pulmonary function, your muscle mass, and your GFR, or else we're really, So I wanted to give
in
our
NFL
Vice Chancellor of Health Affairs, Steve Goldstein, who joined us. Thank you. Steve, did you have any comments?
I'm sorry. First of all, welcome, Keith. I'm sorry that I was late. In what I heard, you've enunciated more clearly than I've heard in lecture after lecture after lecture how I want to think about this in a way that makes sense. And I'm gonna at the risk of failing the test, I'm gonna try and say what I think I heard, which is. Okay. And it comes from a sense of anxiety. About 25 years ago, I did a study where the net result was we showed that a particular mutation in an ion channel gene predisposed African-American babies to sudden infant death by a factor of 10 over Caucasians. And then since the world of that, I'm sitting there saying, all right, I took samples from patients that were described as Black,
right,
and white. It was the best I could do, but oh my God, have I done something that made no sense? And if I understand what you're giving me permission again to say, we can use it to screen and to study. And then when it comes to the individual patient, it's okay to say, there's an increased risk, we believe, in someone of your race or ethnicity. So we should screen and see if this is relevant to you. Is that saying it right? Or
so that I'm not saying it's so there is a struggle with a lot of people in this space around that. So I think if we see, to me it's reasonable that if for reasons we don't know, there's a much higher prevalence of a particular we'll say gene polymorphism or whatever it is that we find in a particular group, and we don't know, any more than that. But and the prevalence is so much greater than it is in any other group that and we don't have a lot of resources. Then we want to screen in the groups where we think we're more likely to find it, right?
Okay.
So right, and that's all. And as long as we do that, we're fine. Since we don't know, right? We don't know if that gene polymorphism is maybe it's just activated because of some epigenetic or gene environment changes due to what's going on with one group and all these other things. So so we have to be careful about how we, what we say about what that means. But I think the observation is an observation, and the population, what we don't want to say is we don't know that that is relevant for every person of that group globally, right?
Right.
But I think, but I think that information is still helpful. And if I was a member, if I was taking care of someone and I said, we have this, I'd say, I want to check it to see whether or not you have it.
Right.
I think that's
Okay.
reasonable,
All
right?
right. I mean, I
that's a lot
still
different than
feel,
saying,
I still feel like just because these were the pathologist said that these were African-American children, how do I know that that was even true? I mean, I have so many questions I still would love to learn from you, but
because if people come, if Australian Aborigines come to the United States, they will be labeled African-American or Black, right? Do we think that they have the same quote unquote genetic architecture as people from South Africa or North Africa?
Right, of course not.
And the people in North Africa probably have a closer genetic architecture, many of them, to the Mediterranean and Southern Europe than people maybe in Southern Africa because of gene admixture and stuff. So that becomes the complexity there. And the challenge and the concern is just, trying to then say every person of that group then has that gene or that risk.
So everybody, our time is up. Keith, what a delightful talk. Thank you so much. We'll continue to interact. I neglected to mention, of course, that Keith has been working with us closely, and you mentioned this on the SEAL initiative. And we've got so many projects working together. We're all going to be hearing more from you, Keith. Thank you so much for taking the time. We really, really appreciate it. And we'll continue to work on what we need to do to make all this actually happen. Okay. So thank you so much.
Looking forward, and great seeing everybody.
Everybody have a great week. Stay healthy, and we'll be in touch really soon.
Okay.